Pediatric Emergencies Part 7. In this lecture, we're going to discuss endocrine emergencies, hematologic emergencies, oncologic emergencies, and immunologic emergencies that affect the pediatric patient. Endocrine emergencies. Children and young adults are much more commonly diagnosed with type 1 diabetes and are susceptible to DKA, a life-threatening event. Hypoglycemia can be particularly damaging to the developing brain. Children are at varying stages of cognitive development, so maintenance of blood glucose levels within the normal range can be challenging. A low socioeconomic status is associated with an increased incidence of DKA, poor blood glucose control, lengthier hospital admissions, and it is essential that the family be involved and supportive to increase compliance. The first disease process we will talk about is hyperglycemia. Hyperglycemia is an abnormally high blood glucose level and can be presenting problem with new onset diabetes mellitus or a complication with a known history of diabetes. It can result in severe dehydration and DKA if not recognized or promptly treated. During your assessment, you'll typically find one of the following: the dose of insulin was missed, or a greater proportion of food was eaten compared to the dose of insulin, or there was a malfunction of an insulin pump. The signs and symptoms depend on blood glucose level. During the assessment, you should ask the following: insulin administration, functioning of the insulin pump, changes in urine output or mental status, patterns on recent glucose checks, presence of urine ketones, or any other symptoms. Management begins with 100% oxygen or assisted ventilation if needed. Hence, if needed, you should monitor your vital signs very closely and obtain IV access and administer isotonic fluids. A 10 milliliter per kilogram bolus may be administered when you suspect shock. Repeat as needed to maintain adequate perfusion. Up to 40 milliliters per kilogram total infusion to maintain adequate perfusion. There is a risk of cerebral edema with rapid IV fluid administration, so you should run your IV fluid slowly during transport if needed. If the patient reports worsening of a headache or mental status deteriorates, you should discontinue fluids. Look for signs of increasing intracranial pressure and also monitor your ECG. Hypoglycemia is going to be abnormally low blood glucose levels. Infants and children have limited glucose stores, and so when the child becomes hypoglycemic, this can lead to irreversible brain damage. May occur in patients with diabetes. In children, alcohol intoxication increases susceptibility to hypoglycemia and altered mental status. The blood sugar level may become too low if the patient with diabetes has taken too much insulin, not eaten enough food, overexercised and burned off sugar faster than normal, or experienced significant physical or emotional stress. Early signs and symptoms include hunger, weakness, irritability, and agitation. Later signs include cool, pale, clammy skin, tachycardia, tachypnea, abdominal pain, dizziness, and confusion. And again, the severity depends on the blood glucose level. So your goal is going to be to raise the blood glucose level. Maintain ABCs and establish vascular access. Normal saline at a TKO rate unless signs of shock are present. If signs of shock are observed or if the child is dehydrated, give a fluid bolus of normal saline at 20 mL per kilogram as instructed by medical direction. Reassess the child's response. Determine the child's blood glucose level. If the level is low, treat with dextrose. Recall that dextrose concentration and dosage are age dependent. If IV access cannot be established, medical direction may order glucagon IM or intranasal. If given, place the child on his or her side after administration unless contraindicated, because glucagon may cause nausea. Give oral glucose gel only if the patient can swallow, has a gag reflex, and is alert or can be roused to alertness. Repeat a blood glucose level reading 10 to 15 minutes following the administration of glucose. Reassess frequently thereafter until the level stabilizes. Congenital adrenal hyperplasia. This is an autosomal recessive disorder of an enzyme responsible for the metabolism of cortisol and aldosterone in the adrenal glands. The most common form is due to 21-hydroxylase deficiency. Males born appear normal, although some may exhibit signs of puberty as a toddler, including increased musculature, penis growth, pubic hair, and a lowering of the voice. Females may also be masculinized. In CAH, patients sometimes undergo early puberty development, pubic hair growth, early growth acceleration, development of facial hair, a short stature, and even severe acne. When the child becomes sick, the body may not be able to compensate. Dexamethasone may be prescribed to a pregnant woman prior to the infant's delivery if the condition is diagnosed early in the first trimester of pregnancy. Infants may have vomiting, poor weight gain, and dehydration. If suspected, hydrocortisone and IV boluses of normal saline are needed. Stress dose steroids should also be considered. Hypopituitarism. The pituitary gland does not produce normal amounts of some or all of its hormones. So the pituitary gland is located at the base of the brain, and it produces 8 hormones. Examples include growth hormone, adrenocorticotropic hormone, follicle-stimulating hormone, thyroid-stimulating hormone, and antidiuretic hormone. Panhypopituitarism is an inadequate production or absence of pituitary hormones. The pituitary gland does not produce normal amounts of some or all of its hormones. This can be congenital or secondary to tumors, infection, or strokes, or develops after trauma or radiation therapy. Because several pituitary hormones affect production of secretions of the adrenal glands, patients with panhypopituitarism can be at risk for adrenal crisis. When stressed or sick, patients can present with symptoms similar to CAH, including hypoglycemia, dehydration, poor weight gain or weight loss, vomiting, muscle cramping, weakness, dizziness, hypotension, and tanning of the skin with gradual onset. These patients require IV fluid boluses with normal saline, glucose replacement, and replacement of steroids with IV hydrocortisone. Management by pediatric endocrinologists is important. There's not a lot of pre-hospital care that we can provide for these patients. Inborn errors of metabolism. This is a group of congenital conditions that cause either accumulation of toxins or disorders of energy metabolism in the neonate. Characterized by failure to thrive and vague signs such as poor feeding. May be a family history of the disorder. However, many are recessive, so family history may not be obvious. These patients are grouped into 2 categories: disorders that result in toxic accumulations or disorders of energy production or use. The disorders that result in toxic accumulations, you have maple syrup urine disease, a genetic disorder that causes a buildup of amino acids, leucine, isoleucine, and valine. In phenylketonuria, the body's inability to break down the amino acid and phenylalanine. Disorders of energy production or use include hereditary fructose intolerance, a lack of aldolase B, the enzyme responsible for breaking down fructose, or galactosemia, the inability to break down the simple sugar galactose. Symptoms can vary and include loss of milestones in development, recurring vomiting and diarrhea, skin problems, dental deformities, deafness, blindness, various cancers. A neonate with sepsis or who is critically ill should be assessed for an IEM, or an inborn error of metabolism. Dietary restrictions and replacements can control many of these disorders. Boluses of glucose and the use of 10% dextrose fluids may also be necessary. Hematologic, oncologic, immunologic emergencies. Hematologic, oncologic, and immunologic diseases are common in pediatrics, ranging from cancers to bleeding disorders to immune deficiencies. Children may be immunosuppressed for several reasons, and children may present with severe illness and shock. Early recognition of shock and initiation of IV fluids can be extremely important. Children have a great capacity, as mentioned earlier, for compensation when in shock, greatly increasing their heart rate to increase cardiac output, so hypotension is a late finding. Tachycardia associated with a fever or hypothermia should indicate possible sepsis. When patients are ill, the oxygen carrying capacity of hemoglobin is altered, resulting in decreased oxygen carrying capacity. Oxygen supplementation is important if you suspect sepsis. So special considerations include sepsis, acute chest syndrome with sickle cell crisis, stroke with sickle cell crisis, tumor lysis syndrome, and increased overall risk for infection. Patients with abnormal hematologic systems include bleeding disorders or blood cancers, and may also have increased or decreased tendencies to clot. You want to quickly assess for signs of sepsis and decompensation. Patients with congenital or acquired immunodeficiencies are at high risk for recurrent infections and invasive disease. Bacterial, viral, and fungal organisms can quickly lead to severe morbidity and mortality. This is called an opportunistic infection. Quickly assess the patients for signs of sepsis and decompensation. Examination should include a thorough lung, circulatory, and neurologic exam, evaluation of the extremities for swollen joints that could be a sign of infection, hemoarthritis or bleeding into the joint, or a pain crisis. Delay in capillary refill and diminished peripheral pulses can indicate early sepsis. Treat with aggressive boluses of isotonic fluids. Because some patients have indwelling catheters, you also want to evaluate the catheter site for bleeding or erythema, swelling, tenderness. Also look and see if these patients have central lines such as Broviacs and Porticas, and evaluate for redness, swelling, and tenderness as well. Sickle cell disease is a genetically inherited autosomal recessive disorder of red blood cells. It causes the red blood cells to be misshapen, resulting in poor oxygen carrying capability and potentially lodging of the red blood cells in the blood vessels or the spleen. Leads to vascular occlusion and subsequently to ischemia and painful crises. Sickle cell vaso-occlusive episodes can be precipitated by hypoxia, infection, fever, dehydration, cold environment, and acidosis. Infants may present with fussiness, irritability, crying, poor feeding, or nonspecific findings, and older children may report pain in specific locations, including joints, back, and chest. Opioids are often started early in childhood and continue throughout adult life to manage the pain due to vaso-occlusive episodes. These medications are sometimes inadequate in controlling severe painful episodes. When obtaining the patient's history, ensure you ask about any medication taken since the onset of the present pain. Treatment of patients includes giving oxygen to prevent further destruction of the red blood cells due to hypoxia. Medical direction may instruct you to give IV fluid. This counters a patient's dehydration and also flushes the damaged red blood cells from the organs and peripheral tissues. And opiates will likely be ordered for pain control as they are a standard of care for these patients. A bleeding or clotting disorder is an abnormality in clotting of the blood. Development of a blood clot called thrombosis can occur in either arterial or venous blood vessels. The symptoms will depend on the following: location of the clot, the size of the clot, or whether the clot becomes dislodged and travels to another part of the body. Most bleeding is a result of trauma, but with a bleeding disorder, bleeding may be more severe or spontaneous. Thrombocytopenia is abnormally low number of platelets. Several causes, as you see here: infections, cancers, rheumatologic diseases, splenic sequestration, inherited conditions, medications, and chemotherapy drugs. Treating the underlying cause if present, transfusing platelets if bleeding cannot be controlled, and transport for consultation with a hematologist. Hemophilia is a genetic disorder usually inherited from the mother. It's a significant disease in one of the clotting factors or proteins in the blood that work with platelets to help blood to clot. In this disease, it's more difficult for bleeding to stop, and a child with severe factor deficiencies can experience hemorrhage even after minor trauma. It's not curable, but treated with replacement of the missing clotting factor. Be alert for signs of cerebral bleeding, which may include headache, slurred speech, or altered mental status, and also be alert for signs of GI bleeding. Provide supportive care, including oxygen if needed, and IV fluids if hypotension is present. Von Willebrand disease is a bleeding disorder in which the patient is missing the von Willebrand factor, a protein essential for platelet adhesion. It prevents the blood from clotting well, and most people with the disease are undiagnosed. Leukemia and lymphoma. In children, two forms of leukemia are generally recognized: acute lymphoblastic leukemia and acute myelogenous leukemia. At its onset, the child with leukemia often displays a few symptoms. The condition may be diagnosed when a child has had a minor infection, such as a cold, but continues to be febrile, listless, and pale with little appetite. Parents seek medical attention upon noticing weight loss, bruising without cause, and complaints of bone and joint pain. Treatment of leukemia or lymphoma includes use of IV chemotherapy and radiation therapy. These patients may require supportive care and pain management en route to a facility. This concludes Part 7 of Pediatric Emergencies. If you have any questions, please contact me, Nick Ray, at suscc.edu.